Thank you for making the time to watch this educational video. What I'd like to share here is how my thinking has evolved over time around metabolic and longevity medicine, particularly as it pertains to cardiovascular disease. In this part of our series, we specifically focus in on atherosclerotic cardiovascular disease, ASCVD. I can say that I certainly didn't come out of my medical training with the intention of running a longevity clinic. I was largely practicing sport and metabolic medicine, weight loss, insulin resistance, low carbohydrate approaches alongside the guidelines, and managing risk factors in the usual way early in my career. But my interest deepened when I started engaging with ketogenic diets for diabetic management in particular, initially through the work of Tim Noakes, but then also seeing the real-world improvements that were occurring in my patients in terms of their pain, osteoarthritis, and metabolic health. Another major influence for me was Dr. Peter Attia and his podcast, because of his insatiable curiosity and thirst for knowledge in the field. Over the last decade following his work, he's consistently asked incisive questions of very serious thinkers, particularly around the dominant causes of mortality, or what he calls four horsemen. ASCVD sits at the top of that list. And as I read more deeply into lipidology, particularly the work of Tom Dayspring, it just became very clear that what we call normal in our population on the bell curve is not necessarily biologically safe. Now add to that a depth of discussions and with focused clinicians like Dr. Peter Bruckner, Dr. Paul Mason, it's become clear to me that there are very differing approaches to improving metabolic and cardiovascular health. And it forced me back to think about first principles. What I'm presenting here is really the culmination of this curiosity filtered through my own experience and practicing with this 3.0 style of medicine as a specialist over the past several years. So cardiovascular disease, when we talk about mortality, morbidity, and quality adjusted life years or QALYs, dominates the conversation. And no matter how you approach it, through epidemiology, through guidelines, mechanistic biology, it remains the number one limiter of lifespan and health span in Western societies. What really shifted my mindset here was reframing it as an exposure disease rather than an event disease. The events happen late, but the biology starts early. And that framing shows up repeatedly. If you look across Mendelian randomization studies, you look throughout the lipidology literature, this isn't just heart attacks, it's stroke, angina, peripheral vascular disease, often with a sudden first presentation. And even when lifespan is preserved after a major cardiac event, health span takes a significant hit. So if we're serious about longevity medicine, we've got to be very good at managing this problem and preventing it. We're dealing with a disease that evolves silently over 30 to 50 years, but we mostly assess it in research and management using tools designed to predict short-term events and medium-term events. And that disconnect is important. I don't think clinicians are doing anything wrong. I mean, the tools we're given are unfortunately limited by design. 10-year risk calculators are useful for deciding who qualifies for a statin today, but they're terrible at identifying who's quietly accumulating vascular disease. Listening to Tom Dayspring discuss ApoB over time, or Attia emphasising cumulative exposure, it really clarified this mismatch for me. Once you accept that ASCVD burden is proportional to ApoB multiplied by time, reassuring a middle-aged person that they've got low 10-year risk becomes quite uncomfortable. And from there, the natural question is, what should we be measuring and how early should we intervene? And that's what the rest of this talk is about, rather than looking at 10-year exposure risk. This slide is simply zoomed out to assess all these different components of cardiovascular risk. And the first concept here on the top left is looking at it as a cumulative process. The risk is not binary, it's exposure over time. It's not about medicating everyone and putting statins in the drinking water, it's about intelligent risk minimization. Risk is not cholesterol today, it's cholesterol multiplied by years of exposure, particularly ApoB. Now over here, for decades we've been thinking cholesterol is the problem, as if it's the causal agent of all heart disease and cardiovascular disease. But when you dig into the biology, and this is where Tom Dayspring was particularly influential, cholesterol itself doesn't drive plaque formation. It's actually the particles that carry that cholesterol. And every atherogenic particle, that's a particle that can form plaque, has the opportunity to interact with the inner artery wall. The risk isn't just how much cholesterol is inside each particle, it's how many particles are circulating and for how long. And that's why two patients with the same LDL-C, the same concentration of LDL cholesterol, can have very different risk. And you can see that illustrated down here. Overall, same total volume of cholesterol, but just with this pure burden of the many particles on the right, in fact, probably carrying less total cholesterol, you can have elevated risk. So from the artery wall's perspective, the right side is far more dangerous. And this is why ApoB, as a measure of cholesterol risk, is so useful. It functions as a simple and relatively cheap count of these atherogenic particles that can form plaque. The last part here is from classic pathology data. So Sterry and all of the data since have demonstrated via autopsy that atherosclerosis doesn't start in middle age. It starts early, often in adolescence. According to these autopsy studies, we've been able to identify plaque formation in very young individuals. And so this is not an argument for medicating teenagers. We certainly don't want to do that. But it's an argument for understanding exposure, biology, and the long-term trajectory much earlier than we traditionally do. So that's the underlying philosophy of this entire approach to prevention of cardiovascular disease. So this scenario here is not uncommon. Same LDL-C measure on the standard lipid panel, very different plaque burden. And once you accept that particle number drives risk, it becomes obvious why the LDL-C can miss disease, even when it's technically normal on the bell curve. I'm no longer reassured when I see normal reference ranges, particularly when there are risk multipliers in an individual, such as they're a smoker, they've got a strong family history, or they have insulin resistance. Now we have the technology and the improved assessment methods that we can much more validly assess cholesterol risk. Ultimately, cardiovascular disease is a disease of the vessel wall, the inner lining of the vessel wall, the endothelium. Now this layer is like an internal skin of the artery wall, and it's only one cell thick. It's very thin. It regulates tone, immunity, clotting and coagulation, and permeability. The ApoB tells us how many particles are knocking on the door, but the endothelial health determines how often that door opens. And this is where lipidology and metabolic health converge into a single story. Cholesterol, it's important to understand, doesn't circulate freely. It needs to be carried on proteins because it cannot dissolve in water. So it's essential to life. We need it to make our hormones, to protect our cell walls, but it has to travel inside these lipoprotein particles. And those particles differ in their structure, their protein coding, and their behavior. Broadly, HDL and LDL are the two main types, and they carry cholesterol. The cholesterol is the same molecule, but the behavior of the ships that carry those cholesterol molecules determines risk. So rather than us looking at the total cholesterol, we need to start looking at the carriers of cholesterol. And then much of lipidology starts to make more sense. So every atherogenic or potentially particle that can produce plaque carries exactly one ApoB molecule. There are no exceptions. So ApoB is effectively a particle head count. It tells us how many atherogenic particles are circulating, regardless of the total cholesterol content in those particles. And more particles means more exposure to the artery lining and more opportunities for the cholesterol to get under the skin of the artery and more plaque over time. And that's why cardiovascular risk tracks so well with cumulative ApoB exposure multiplied by time. Here you've got the identical LDL-C with very different particle biology underneath. As we've mentioned, the LDL-C tells us how much cholesterol is involved, the little yellow parts, and the ApoB tells us how many particles are doing the carrying. And once again, just to really hammer this home, each particle and the particle count is what we should be measuring to make clinical decisions on lifestyle and medical treatment. Believe it or not, ApoB particles cross the endothelium constantly, so that phenomenon alone is normal physiology. The pathology begins when these particles are trapped or retained in this subendothelial space here, and that can then trigger modification of the cholesterol or oxidation that triggers inflammation and initiates plaque formation. More particles means more crossing, more chances of retention and trapping, and more cumulative plaque disease. And once particles are retained, the cascade is fairly predictable. Particles become modified by oxidation, then they recruit immune cells called monocytes and macrophages in an attempt to mop up the debris and clear them out, but this system can become overwhelmed with chronic exposure. And then fat-filled cells called foam cells accumulate, forming early plaque. It's important to realise that we very clearly know that dietary fat intake does not equal plaque formation, which unfortunately this visualisation often suggests to us. In any case, this process remains clinically silent for decades. By the time there is stenosis or narrowing or rupture occurs, the biology has been running for a very long time. And this is why early intervention matters, not because plaques appear suddenly, but because once the cycle's established, reversal becomes much harder. And this slide explains a lot of the frustration that we see clinically and a lot of the confusion as well. Most risk tools estimate the chance of an event in the next 10 years. They work reasonably well in older, higher risk groups, but heart disease does not work on a 10-year timeline. It is a limitation of medicine and the way we've designed our studies around this and our management. But younger and middle-aged people can have significant plaque building up and be labelled as low risk. So the calculator isn't wrong, but it's answering the wrong question if it's used in the wrong patient group. What I like in particular about ApoB is that it answers a very basic question. How many atherogenic particles are circulating here? It outperforms classical LDL measures. And if we look at Snyderman's research from the last couple of decades, we know that ApoB captures LDL and VLDL risk, and it performs better than LDL-C, particularly when there's comorbid insulin resistance, and consistently it is more discriminatory in terms of atherosclerotic disease. So the real questions now are how early do we measure it and how do we act on it proportionately? Now, Snyderman's research also tells us about a thing called disconcordance. And this is where LDL and ApoB can go in different directions. Usually that's in the presence of metabolic disease. We find that ApoB consistently performs better because it tracks well with small, dense LDL particles, which can be measured with a more expensive technique called NMR or electrophoresis. So when LDL-C and ApoB disagree, ApoB is the signal to trust, and when ApoB is low, we can be reasonably reassured, other than one major exception. Lp(a) is an ApoB particle that is genetically determined, and it's both atherogenic and prothrombotic. About 20 to 30% of the population have elevated Lp(a), making it a once-in-a-lifetime test. It's thought to confer some protection against bleeding, which would have given some survival advantage to our ancestors. But with high Lp(a) or a strong family history, ApoB and LDL may be normal, but the stickiness of each particle and therefore the cardiovascular risk may still be substantially elevated. When it's high, the strategy shifts to aggressively lowering cumulative ApoB exposure. In select patients, LDL subfractions can help refine particle behaviour and identify and quantify small, dense LDL particles. And these are the ones that we really want to target for the treatment rather than LDL alone. They are the more harmful components of LDL. Sterols testing helps us distinguish between synthesis versus absorption, and they assist in therapeutic decision-making, particularly around diet and medication options for high-risk patients with elevated markers already. So these are all adjunctive tools. We don't use these as screening tests, only selectively to personalised management. Two patients can have the same ApoB, but very different risk trajectories, depending on their metabolic health. Insulin resistance increases VLDL production, which is a type of particle made by the liver, and this worsens endothelial function. It also worsens systemic inflammation. And these processes can also lead to something called glycosylation, which makes these ApoB particles more likely to form plaque. So although ApoB tells us how many bullets are circulating, markers of metabolic health determine how much damage each particle does. So while blood markers can help estimate future risk, imaging detects existing risk. And the two major tests around the arteries supplying the heart are the coronary calcium score and the CT coronary angiogram. Calcium scoring identifies calcified plaque, and it's got a lower radiation dose. CTCA angiogram visualizes the non-calcified vulnerable plaque, but it comes with a higher radiation dose. They answer different questions, but they're complementary in most cases. In select patients, a CT coronary angiogram is appropriate, usually along with a cardiologist referral. Here you can see that this multi-center study called the Scott Heart Study showed that a CT angiogram can really help identify high-risk patients. They found that patients who had what's called low attenuation plaque burden had predictably higher risk of heart attacks independent of artery narrowing. So the quality of the vessel wall is more important than how narrow the vessel is. And this explains why a normal cardiac treadmill test, which is normally good at picking up existing narrowed arteries, can't actually help us predict future heart attacks very well. It also helps us understand why some patients who have minimal artery narrowing still have a high risk of stroke and heart attack. And it's taught us why plaque biology and stability matters more than just narrowing of arteries. Because usually a heart attack involves clots forming in a vessel after the vessel wall has eroded, a plaque has ruptured. And again, vessel quality more important than just narrowing. These sorts of findings shift management toward earlier and more aggressive risk reduction, even when calcium scores are low. So I think about this as a timeline. The blood markers are where someone's heading, and the imaging is where they are now. If you look at these curves, late intervention still helps, but you're always playing catch up. You flatten the curve, but a lot of damage has already been banked. Early intervention, even if modest, at the right age, can significantly shift the entire lifetime exposure downwards, and that translates to a disproportionately larger benefit. It improves our runway. And this is where 10-year risk models fall down. They're blind to what happened before the age of 40 or 50. Someone can have decades of elevated ApoB exposure and a low calculated 10-year risk, but still be well on their way to a first event. So this is how all that thinking actually translates into practice of PSN. We start by measuring causal risk, not surrogates. ApoB tells us how many particles are in the circulation. Lp(a) flags genetically mediated risk that lifestyle won't unfortunately change. And that's the biological substrate. At the same time, we look for accelerators, insulin resistance, visceral fat, high blood pressure, inflammation. These don't cause plaque on their own, but they dramatically speed up the process, add fuel to the fire, and make arteries more vulnerable to the ApoB exposure. And when it's appropriate, we look directly for disease, calcium score, and the angiogram. They're not screening tools for everyone, but used selectively, they're very helpful in understanding established biology and what's already underway. Then comes intervention, early and proportionate. Exercise is the foundation. Nutrition, sleep, and stress management all matter, and medication is about judiciously using our toolkit with the right tool for the right job when the biology warrants it. The key point is this: the goal is not zero risk, that's just unrealistic. The goal is to slow things down enough that disease never becomes clinically relevant in that person's lifetime. The content here is provided for general educational purposes only. It is not intended to be medical advice, does not replace consultation with your own doctor, and should not be used to make individual health decisions. CVD health risk screening and treatment decisions depend on your personal medical history, family history, and individual risk factors, and should always be discussed with a qualified health professional. No patient-doctor relationship is created by viewing this content. If you have symptoms or health concerns, please speak with your GP or treating specialist.